Okay, so we are going to talk about the microvascular free flaps. Now, head and neck reconstructive surgery is a very challenging discipline. Now, as we know that this part of the anatomical structure deals with many functions. So you must have read about, the in your probably first year or in your first year of graduation about the anatomy of maxilla. The anatomy of maxilla is so complex. We never know कि ये उल्टा कैसे और सीधा कैसा है. It has got so many surfaces, so many processes, so many attachments. So this is how the complex anatomy of head and neck, and it's very difficult or it's very challenging when we try to reconstruct this with the functional anatomical reconstruction. So now when we reconstruct, we restore the functional anatomy, and an important area where we need to achieve a balance between the swallowing, occlusion, deglutition, and the appearance, or you can say aesthetic. Now, all these years, since last 5 decades, PMMC flap, we call it as a pectoris major micropens flap, has been, a kind of workhorse for reconstruction because it was easy reconstruction. It was the same site. It can be done by same surgeon, but it carries its own disadvantages. So probably you might have seen people around you, people who have been operated for cancer, that all head and neck reconstruction was done by PMMC flap. They will have a lot of problems. They will have a lot of problems with aesthetics, functions. They always will have pain in the operated site. If we remove the mandible, put just PMMC, there will be deviation, occlusion will be gone. So there are a lot of issues which were with the PMMC flap. So there was a need of a better reconstruction, and that is how there was a need of there was an induction of microvascular free flap which have come. And in today's date or today's era, this has taken as the workhorse of reconstruction at many centers, and we are doing the standard of care microvascular free flap reconstruction for reconstructive these post-oncological defects. So let me take briefly into this reconstruction portion that you must have probably read, or same principle as we have read in our probably the dentistry. The principles of reconstruction is form, function, and aesthetic. Now when we talk about form or integrity, so why it is important? As I said, these anatomical structures deals with different functions. So now if I talk about lips, so lip is, it involved with it's swallowing, it involved with the oral competence, with the speech. Many things are related to the lips. If you do not reconstruct the lip properly, what is going to happen? Patient will have drooling, patient will have difficulty in speech. 1 minute, I think it is gone. Okay, patient will have difficulty in speech, patient will have drooling, aesthetics will be compromised. So same way, like lip, palate, again, if we operate for palate, if we do not do the reconstruction, there will be a lot of regurgitation issues and voice problem with that. So like that, we have lip, palate, tongue. We need to replace, we need to reconstruct these tissues, this structure adequately to prevent all these problems. So second is the function. As I said, there are many important functions which are related to this maxillofacial or head and neck region. So this is something mastication. We are not going to get into details of this individual function because you all are oriented enough to know what is a mastication, how it helps swallowing, speech, facial expression. When we talk about facial expression, it's important is whenever we are operating a salivary gland disease, it is important to preserve the seventh cranial nerve, that is called facial nerve. Otherwise, patient is going to have facial nerve paralysis that might compromise your aesthetics. So these are the things which are importantly we should be considerate when we are operating or reconstructing. So the best part is aesthetics. Now we being the maxillofacial surgeons, I think we are the best person who can recreate or who can give the best aesthetics when it comes to maxillofacial reconstruction. So earlier in our when we were students, probably a few years back, we have been taught, as Deepak said, the textbook had written what which is since last 20-25 years we were reading the same textbooks. So this is according to the textbook, but now this is being changed. Now this is a reconstruction ladder. Now why it is called a reconstruction ladder? Earlier we used to think first we should go for primary closure, then a bit skin graft, then local flap, then regional flap, then free flap. Because probably 15-20 years back, free flap, it was done by a handful of surgeons across India. But now, down the line, after 15-20 years, probably this have changed. Now it has come as the reverse reconstructive ladder. Or there's one more terminology which has been used here, is the reconstruction elevator. So many times a surgeon can choose the reconstructive modality based on their skills, based on the availability and the best to the patient. So I can say according to the patient need, fits the patient best, a customized reconstruction can be done for the patient. But when we talk about reverse reconstructive ladder, whenever we are operating head and neck surgery or oral cancer, I think we are unfortunate that 70 to 80% of the patients comes on an advanced stage, and we need a bigger resection. Bigger resection means now if we take a 1 centimeter margin all around, we are going to disturb a lot of tissue. We are going to take out the mandible, we are going to take out the tongue, probably we are going to take out the...
You can carry on with the treatment, no problem.
So sorry, I'll just mute Deepak. Just
Okay.
Yeah, sir, continue.
Done? Okay. So now, why do we need free flap as the first choice? As I said, our resections are very extensive. There are a lot of structures when we are doing the ablative surgery are being removed. And most importantly, all these patients who are coming on stage 4, they will require radiation. So the moment you give radiation, all the other modalities of reconstruction, be it putting a plate, putting free bone graft, nothing works. I say nothing works other than free flaps. Because these patients, when they receive radiation, everything goes. If you put a free bone graft, it will just resolve, it will go necrosed. If you put just a plate, the plate is going to fracture. And there are a lot of issues which a patient may face. Ultimately, a doctor has to answer all those things. So, keeping all those things in mind, we are doing free flap as our first option when we talk about the post-cancer ablative reconstruction. So there are various kinds of reconstructive flaps are available. So there are pedicle flaps and there are free flaps. So pedicle flaps means we can say these are loco-regional flaps. So according to the patient, at times we might use these kind of free flaps like forehead flap, PMMC flap, nasolabial flap, deltopectoral and latissimus dorsi. So these are the loco-regional flap which can be used for reconstruction. And we are today going to talk or discuss all about the free flaps, that how free flaps are being done, from where these free flaps are harvested, and what are the advantages of doing these free flaps. So we are doing radial forearm flaps, we are doing medial sural, we are doing anterior thigh flap, fibula, scapula, we are doing latissimus dorsi, we are doing rectus abdominis and iliac crest, iliac bone grafts. So now, before I get into the details of these free grafts, you need to understand the advantages. Because I tell you, whenever we explain about the surgery to a patient, what is the biggest thing he has in his mind? It is the surgical fear. Surgical fear is considered as one of the important factor for delay in diagnosis. People do not report to doctor, even though they know there's some problem. Why? Because they think कि अगर मैं doctor के पास गया and if he says it has to be operated, what will happen to me? We know that everyone's face is his identity. So nobody wants to get operated on the face. So now the surgical fear is the one of the important criteria or important aspect is surgeon should explain to the patient. If you explain to the patient that post reconstruction you will not have a major impact on your profile, on your function, and if you say with a confidence, keeping with a good eye contact, patient always says yes, and he will be convinced not only for surgery but he will have confidence in you, because this is one of the important things which wherever you are practicing, if you tell your patients, even though you are not doing free flap, but if you can tell your patients that see, you don't have to worry, this can be operated, and in case if you are worried about your aesthetics, there is a newer technique of advanced technique of reconstruction which is called free flap, which you will not have any problem. So that is the reason that I have put few advantages for all of you to just have in your mind how or what are the advantages it carries, why we do so much of free flap or we do first choice as our free flap at our center. So now it is a two-team approach. So when we talk about two-team approach, one team is doing the primary resection, other team is raising the flap. So we save a lot of time. The moment your primary is out, your reconstruction flap is ready to resuture it there to fill the surgical defects. So it saves the time, improved vascularity and healing. Now whenever we talk about wound healing, the important criteria is vascularity. So when we do the free flap, what we do is we are taking the vessels, so that is artery and veins along with the tissue structure, be it bone, be it muscle or skin. We can have kind of complex graft also. So that vein and artery, we do the anastomosis with neck vessels. So it is like we cut the facial vessel, we have taken the artery from the distant side and we do the anastomosis. That is called microvascular anastomosis, because your artery or your veins are hardly 2 mm or 3 mm. So this is all done under microscope. We use 10-0 ethylone for suturing the vessels. Now you can understand that this is a very, very technique sensitive, and it definitely involves a lot of dexterity of your fingers to put the sutures adequately on the vessels, so that after you do the anastomosis, there should not be any arterial clot. No bony resorption. So as I said, if you put just a free bone graft and if patient undergoes radiation, definitely it is going to undergo resorption. If patient doesn't receive radiation also, there are high chances this free bone graft will undergo resorption. The defect size. Now many times, we have seen in our practice that we are not concerned about the defect size. We have to treat the cancer at first instance. So whenever we take the margin, if I have 1 centimeter in my mind, as Deepak said, the minimum margin for Indian patient, we should have minimum of 1 centimeter margin on whenever we are doing the resection. So when we have the option of free flap, we are not bothered that ये defect छोटा होगा कि बड़ा होगा, whether I'll be able to fill it with the local flap or not. These things never come to our mind. So we are more open-minded when we are doing the resection, and adequate resection can be performed. Next is potential for sensory and motor intervention. So what do you mean by sensory or motor? So many times we can harvest the nerve also and we can do the neural anastomosis also. Permit the use of osseointegration implants. So now it is a very important aspect for us to remember, or for us to know. If somebody is undergoing a mandibular resection and he has been put a PMMC flap, can you put the dental implants? Can you do the dental rehabilitation for that patient? No, obviously. So what is going to happen? That patient have to live with that compromised function throughout his life. So now these free flap or free bone grafts, what it makes is it gives a space for putting the dental implants in the future, where dental rehabilitation can be done and he can have improved quality of life. So wider variety of available tissue. As I said, whenever we are doing a resection of mandible, buccal mucosa, tongue, so now there are a lot of tissues. We need to have a lot of tissues to reconstruct individually. If we take PMMC flap, it is just musculocutaneous flap. You just have to fill in, that's all. But in this free flap, we can take bone separately. I mean, the same pedicle, we can have bone, we can have skin pedal, we can have muscle. So all three composite graft can be taken and it can be utilized wherever it is needed. Now it can be tailored to the match defect. आपको जितनी जरूरत है उतना ही आप डिफेक्ट क्लोज करने के लिए यू कैन टेक द फ्री फ्लैप एंड इट कैन बी कस्टमाइज. जितना जरूरत है उतना आप लगा सकते हैं. सो नेक्स्ट इज इट इज पॉसिबल टू रीडू. नाउ एज वी नो दैट ओरल कैंसर, if there's a stage 4 patient, there are 50% chances in next 5 years he will come with a recurrence. Recurrence can happen probably at same site, opposite site, and that is because of the field cancerization, as Deepak has already mentioned. Whenever a patient is chewing a gutka or any kind of chewing tobacco or smoking, it is not the one portion which gets damaged. It is the whole buccal mucosa which is actually damaged. So there are high chances you are treated in one portion, you might develop a cancer, he might develop on the other side. So now you have done a radiation for first cancer. We cannot take local flaps there, because once you have given the radiation, skin becomes very taut. So these free flaps can be used whenever there is a redo surgery. Very low donor site morbidity. Absolutely, if you see our patients, if you talk to the patient will say, अरे हमको तो कुछ पता ही नहीं लगता है कि हमारा कहीं से ऑपरेशन भी हुआ है. You take any graft, be it your radial forearm, be it your medial sural, be it your scapula, fibula, patient have very, very minimal morbidity in that area. So now what are the limitations? Definitely everything has its own limitations. So first is it's a technically demanding. You need to practice for hours and hours, days and days, years and years, because it is a very, very technique sensitive. You need to use 10-0 or at times we can use 9-0 also, but you need to use 9-0 or 10-0 to take the stitches on a very, very minute vessels. So it's a very technically demanding. You need to develop that dexterity in your hands to handle the vessels. Second, high success rate in the hands of expert. Once you have become the expert, I think the success of the free flap for our case is more than 96%, because many a times whenever we talk about the patients that we are going to do this free flap, there are 3 to 4% chances of failure. So now many people think that ये करने से तो fail हो जाता है, PMMC doesn't fail. But if it is done by the expert hands, the chances of the failures are very less. It's a team approach. As I said, the oncology it's a very basically whole oncology is about the comprehensive or the team approach. When talk about the surgical aspect also, it's a team approach. So there's one team who's doing the resection, the other team who's doing the reconstruction. And OT infrastructure, yes, you have to have good quality of microscope to do the anastomosis, do the microvascular work. So these are few limitations. I think that is the reason that still in today's date there are only few centers who advocate the free flap techniques. If I say in Ahmedabad per se, there are only 20% of people who receives microvascular reconstruction. Rest 80% they receive just local regional flaps. So it's time for us to train ourselves. If you're a maxillofacial surgeon, any of you have trained yourself into the field of reconstructive surgery, because that is the need of an hour in the coming time. So now we are going to talk about common free flaps. How do we do it? And some pre-op, post-op results. So at least you have an idea that how these flaps are harvested, from where it is harvested, and what advantage or disadvantage it carries. So the first one is the radial forearm flap. This is a very commonly used free flap, or you can say it is a learner's flap. Whenever we start learning microvascular free flap, this is the first flap we try to learn. This is also termed as a Chinese flap because this has been started in China probably in 1980s. So this flap is basically a faciocutaneous. From here you take it. I'll show you from which portion you take it. So this is where you take the radial, based on the radial artery, there's a ulnar artery. So based on radial artery, you take how much ever is needed. You take this graft along with radial artery, cephalic vein, and vena comitans of the facial artery. So what is vena comitant? For your knowledge, I will tell you. Vena comitants there are usually two veins which are running along the artery. So that is called vena comitants. So whenever we are doing the anastomosis, we usually do two anastomosis, one with the cephalic and one with the vena comitants. So we are not going to get the details of probably the anatomical details. We are not going to get into anatomical details. So this is one of the harvested free flap photo. Now this is how we wanted to have it defect, which is a custom fit. We have taken the flap. You can see there is a cephalic vein and one the lower limb, or you can say that is the the radial artery with vena comitants. Now what are the advantages? Now radial forearm is, at our center probably we have replaced this radial forearm free flaps absolutely with the medial sural free flaps because of few disadvantages which I'm going to mention it about. So but we have few advantages. First is we have very long skin pedicle, easy repositioning. We can do in a two-team technique. We can take the nerve for the sense, for sensation, and it is very easily preoperatively we can do the evaluation by doing the Allen's test. But now, what are the disadvantages? Why we have discontinued this flap, or probably we have taken the medial sural as the first free flap and radial forearm as second. The first thing is poorly aesthetic donor site. I'm going to show you the photo now. What happens is whenever we take the graft from here, we have taken the faciocutaneous graft, we need to put another skin graft, another split skin graft or full thickness skin graft here. So now there are two donor sites. One, we take the skin graft from the thigh or abdomen, we put it here, and this graft we are putting intraorally. So this mark will be there throughout the life. Now how that mark appears, I'm going to show you in the later part of the presentation. So many of these patients, they will always say, "Sab ye mark dikhta hai." We ask the patient to wear, the sports band jo aati hai. Usually we ask the patient to wear and camouflage it. But now with the other free flaps, I think this is not needed. So we are going to have a discussion about how these radial forearm flaps are being used for oral cavity reconstructions or head and neck reconstruction. So this is a case. Now you can see clearly that this patient comes with a lesion on the left side of angle of mouth, which is anterior buccal mucosa lesion. So we are not going to get into details of this resective surgeries. Now we have done the radial forearm flap for this patient. As I have shown how we have harvested, and this is the post-operative photo of this patient. You can see beautifully the buccal mucosa have been replaced with the radial forearm flap. It is so pliable, so easily, the patient can have, a very good competence with this free flap. This is the donor site morbidity I was talking about. That patient will have the skin graft mark always. So one is here and one is on thigh from where we have taken the graft. So there are two donor sites are there in this radial forearm flap. And this flap, over a period of time, it undergoes mucosalization. That means it appears like an buccal mucosa. Many a times there are hair growths in the buccal mucosa if patient has on the hand, but over a period of time that also disappears. So now second free flap, we are talking about the soft tissue free flaps. So ALT, so that is called anterolateral thigh flap. So anterolateral thigh flap we take from the lateral aspect of thighs. So now what are the advantages? You can take a big flap. You can take जितना भी बड़ा चाहिए होता है, you can take a bigger flap. You can take skin, only skin. I mean fasciocutaneous. You can take along with the muscle also. You can take big chunk of muscle. So based on your primary defect, how much is being needed, you can harvest this flap. Secondly, all these free flaps, ALT free flaps, primary closure is done. So there's no donor site morbidity because we are doing the primary closure. Positioning, as I said, it's very easy, two-team technique. One is doing resection, the other person is harvesting it. At our hospital, the moment our primary is done, sent for frozen, neck dissection is done, we are ready with the harvested free flap. So it saves a lot of time, it saves just, we can immediately, the moment the neck is done, we can start putting our flap and start with our anastomosis. So the disadvantages is many times, we get the pedicle length is, sometimes it's a shorter length, and other disadvantage is the bulkiness. Many times the patient who are heavy weighted, they will have big thighs. So many times it becomes difficult to harvest, customize, tailor according to the patient's, the oral cavity need. So that usually what we do is the thinning of free flap or thinning of ALT flap can be done. But definitely it's problematic if the patient's thigh is too thick. Now we are going to have two case discussions. So one is this patient reported to us with a ulcer on lower lip, which is almost reaching up to the vestibule, and it was not eroding the bone, it was just lip lesion. So now what we have done, this is how we have marked. You can see we have adequately away from the skin margin, 1 centimeter away margin. This is how we have done the resection. We have removed the marginal mandibulectomy have been done for this patient. We have done bilateral neck dissection, and this is the specimen. You can see how far we are from the disease margin. We always take 1 centimeter away from the margin. It is a rule for us that we need to stay 1 centimeter away. We can be more than 1 centimeter, but never less than 1 centimeter. So now this is the markings of ALT flap. So anterolateral thigh flap. That's how we have harvested the flap. We have positioned the flap, and this is immediately post-op that we have taken the flap. We have covered intraoral. We have covered extraoral. Now this patient, as you can see, that patient was having extensive disease. That patient received the radiation, and this is the photo post 1 year of radiation. You can see the competence. The first thing what I was talking about is competence. You can see this patient can eat, this patient can drink. There is no drooling per se. So this patient competence is good. See the mouth opening. Now these are two important things usually which doesn't happen with any loco-regional flaps here. Either patient will land up in incompetency, either he will land up into the kind of trismus or decreased mouth opening. I think mouth opening is also a very important criteria which have to be considered whenever we are operating a patient, that make a bigger difference on quality of life post-operatively. So this is the patient, this is how we have reconstructed the ALT, and this is the 1 year post radiation pictures. You can appreciate, again I say, competency and mouth opening is the important thing which is worth noting on the slides. Now we have one more case. It's a very interesting case we had. We get these cases, we usually get very rarely, but this is an interesting case of fibrous histiocytoma of scalp. As Deepak has mentioned, that yes, we do deals with all head and neck cancers, probably except the larynx. We do all kind of resective surgeries, given the reconstructive surgeries. So now this patient came to us with this kind of presentation. So when we have taken to operation theatre, we could mark. Now we have marked 2 centimeters for this patient, not 1 centimeter, because this is an aggressive tumor. So we have marked this. You can appreciate our marking. This is the this is the specimen. Now even after being so away on frozen section, on posterior aspect, in the last photo you can see there was skin. There was few tumor cells can be seen. So on the frozen section, we have again did the revision surgery till the time we get the negative margins on the skin scalp side. So now you can see there's a huge defect. So almost from this portion to this portion, everything is gone. Your bone is exposed, your calvarium is exposed. What reconstruction we are going to do it here? It was definitely a very challenging case. So how we have done is, we have taken ALT flap along with the muscle. Now what we have done, we have spread the muscles. We have spread the muscles on the posterior aspect, and anteriorly we have taken the flap. Now the important issue at this place was anastomosis. Your vessels will not reach from here to here neck. We will not have this much of long length. So there was a very we had struggled to do the anastomosis, and I tell you, we did the anastomosis with superficial temporal artery, and we have done venous anastomosis with supraorbital vein. Probably you might have read in your books. There's a small vein in superior aspect of orbit, that is supraorbital vein. We have used it for anastomosis, and God is great with us. We could do successfully, and this is how the patient result after 1 month of the surgery. So this is how we even see we have put the skin graft on the muscle. We have covered the complete scalp has been covered, and we could cover the calvarium. We could reconstruct it adequately. So that is the advantage of doing a free flap, with such a precisely. So this is the primary defect. As I said, it is just closed primarily and doesn't have any donor site morbidity. So now I think you're not getting bored, because now we are going to talk to you about a third flap, which is medial sural free flap. Now see, the idea behind discussing with you all about this free flap is, as a doctor we should know. As a doctor we can tell our patient that this can be done, this can be done. The options can be given by you, and that can be we can give in detail, but at least patient should know what is the best surgery for them. Because what happens is, the people who are not doing free flap, they will not tell about the free flap to the patients. There's nothing called free flap. See, a patient doesn't know what is a free flap, and many a times what happens is, patient underwent loco-regional flaps. He have many compromised issues. Then through some person they got to know about the free flap. They visit us, sir, ab hamara kuch kar do. And frankly, I tell you, it's very difficult for redo free flap surgery just for facial correction, and that can be only done probably after 2 years of post-operative period of the patient. So a patient should know what is the best available for him, and then let him decide that whether he wants to go for free flap, whether he wants to go for local regional flap. It should not be decided by the operating surgeon कि मैं तेरे को free flap करूँगा, तेरे को local flap करूँगा और तेरे को skin flap करूँगा. I think that is very important thing. We should leave this decision to the patient, giving all the available options, and that is what we are doing. We give all the options. We are not hard and fast about doing the free flaps, but yes, we do give all the options. We tell about the advantages, we tell about the disadvantages, and let the patient decide and revert to us, sir, I want to undergo this free flap or this kind of flap. So now we have a very interesting flap, that is medial sural artery perforator flap. Now, as I said, that radial forearm flap is being, we have slowly we have replaced with this flap because it has its own advantages. So I'm going to have a small discussion about this medial sural artery flap. So now I'm not getting into the details of this flap. Only issue with this flap, why not many people are doing across the country, is the vessels are very thin. Secondly, it comes out through the muscle, so you need a very precise dissection of the pedicle from the muscle, and the vessel diameter is very less, artery is hardly 1 mm, so it is difficult for anastomosis also. So this is not being routinely being done. There are a handful of surgeons who are doing medial sural free flaps in this country. So now we are going to have 2 small case discussions. Like this is the patient. Usually you might have seen or you will see in your coming practice these kind of lesions. जहाँ आपको लगता है एक छोटा सा ही तो lesion है. There's a small lesion there in the, you can see in the on the alveolus or GB sulcus. Now we have done the biopsy. This came out to be positive. So don't think that's a small lesion, that means he will require a small surgery. No. Again, that is a wrong concept. I think what my boss used to say is, you need to treat stage 1, stage 2 patient adequately. You need to do the best of reconstruction, because these patients are going to live long, and definitely they require very good quality of life, and that is where we do, that's how we have done the surgery. So this you can see adequately, even though it was a small tumor, we have done the marginal resection. We have removed a cuff of tissue along with your ulcer, and this is the medial sural. This how we have raised. This you can see in the second slide. Probably if you can appreciate, there's a bluish line there. You can see it's a bluish thread. So that is the pedicle. It's a very thin pedicle. If you still want to appreciate, you can see in our photo that this small thread, it is containing 1 artery and 2 vessels. Now imagine getting, separating these vessels, separating all 3 vessels, doing anastomosis. Definitely it requires a lot of skills. So now this is post-operative result. As Deepak mentioned, this patient, he comes and always he says, साहब मेरे को देख के लोग कहते ही नहीं हैं कि मुझे कैंसर का ऑपरेशन हुआ है. Now that is, I think, the best compliment every doctor want to hear after a cancer surgery, कि साहब मेरे को कैंसर का ऑपरेशन हुआ है, लोग कहते ही नहीं. And that is where you can see we usually don't do the lip split, we only use the neck incision, and that is how our reconstruction is being done. So when we talk about the quality this patient has, this is the best quality of life probably we could have given to him. We have one more case, because these are the common cases. We have kept very common cases, no high funda, no advanced cases. So we have kept 2 cases very commonly. You will see a small ulcer in GB sulcus, or you will see a small ulcer on tongue. Now this patient comes with a small ulcer on the tongue. Small ulcer means probably it is 2 into 2 centimeter or hardly less than 2 centimeter. Now many people think that ये तो छोटा सा है, इसको तो ऐसे ही निकाल देते हैं. As I said, no cancer surgery is small surgery or big surgery. Cancer surgery is a cancer surgery. So for this patient, again, what we have done the adequate partial glossectomy is being done. We have done the neck dissection. As somebody was asking how many levels we need to clear. For tongue, usually we do level 1 to 4 resections. Level 1 to 4 nodal dissection has been done. We call it as extended supraomohyoid neck dissection. So now there are two options when we talk about this kind of resection and reconstruction. We can just primary close it. Okay, primary close it. Now what happens with primary closure? We need to deviate the tongue. The tip will get deviated to one side. Secondly, the bulk will be in the center of the tongue. So there are a lot of issues. It is difficult for you to probably imagine that what if this patient undergoes a primary closure. It is difficult for you. But we have seen that this patient, if you do a primary closure, there are a lot of issues. Yes, this patient, we could have done the submental flap, or we could have done any other flap, localization flap. But as I said, patient was interested. Patient said, I want to go for free flap surgery. Now, this is the kind of margin we mark it. You can appreciate our markings. Again, I say more than 1.5 centimeter in tongue. This is the primary defect. So even though your disease is so small, your disease is 2 centimeter, you need to take it out 1.5 centimeter on this side, 1.5 centimeter on this side. So you are actually removing around 5-6 centimeter of tongue. So now when we take out the 5-6 centimeter of tongue, it is important to reconstruct. So what we have done, reconstruction for this is, we have taken this medial sural free flap. Now in this photo you can appreciate better this how we do the flap dissection. This is a medial sural flap. This the skin is a fasciocutaneous flap. So this is the post-operative result. Now you can see the patient tongue. You can see the midline. The midline is exactly the tongue is not deviated. Now from wherever we have done the surgery, it is we have placed a medial sural free flap there. So patient doesn't have any difficulty in deglutition, mastication, speech, anything. So that is where our principal have taken into consideration and done the best of reconstruction. We have presented our paper in Seoul about comparing the medial sural and radial forearm free flaps. So now we'll come to the bony reconstruction. So I hope you're not getting bored. Probably so we talk about now. We are going to talk about the bony reconstruction, and we'll take up your questions. So bony reconstruction, as I said, it's very important. Now mandible is a single bone. We say, we have read in our anatomy, this is the only strongest single bone in our whole body. So whenever, and it has got a dentate or it has got the teeth attachments. So whenever we are doing the resection, what is going to happen is, we are not removing the teeth, but your mandible will get deviated if you do not reconstruct it adequately. So there are various techniques of reconstruction. Usually in earlier time, what people used to do it, they used to just put a plate. कि ठीक है चलो plate लगा देते हैं बाद में देखेंगे. They used to put a plate and then put a PM. There were many things, many things were being done all these years. They used to take rib graft or take iliac graft. All these things have been done. But now, only best possible modality in today's date across the world, I say, is the free fibula or free scapula bony reconstruction. So fibula fibula is, we have got two bone. Fibula is a non-weight bearing bone in the leg, which can be utilized. It is based on peroneal artery. So we are straightway will get into two cases of fibula, probably one case of fibula and two cases of scapula. So this is the patient who has reported to us with ulcer on the left side of buccal mucosa, RMT region. So we have removed almost, crossing midline from canine region to the, you can say, subsigmoid. We have removed the whole mandible. It's an extensive surgery. It has been done. Now, what happens if you do not reconstruct these anterior segment with free fibula or any bony graft? So now there's attachment of genial tubercle. There's attachment of important muscles of tongue that is called genioglossus. Now, genioglossus muscle, it is attached to this genial tuberculus there. So what happens? The moment the attachment are being cut, the tongue falls back. So it is important for us to reconstruct this defect. Whenever we are doing a bony reconstruction, we need to reattach these fibers of genioglossus to newly reconstructed bone. Otherwise, patient throughout his life is going to have gag reflex, is going to have difficulty in speech, difficulty in swallowing, difficulty in eating. And in these cases, if anyone puts a PMMC flap, you can imagine his quality of life. I say he cannot eat throughout his life. I have seen many patients who have been operated with central arch, just putting a PMMC flap. Patient have to lie down to drink something to fill up their stomach. I think that quality of life we do not expect anyone to have. So that is where the role of free fibula comes and gives, enhances the quality. So now you can appreciate our results, that this is the pre-operative picture of the patient. This is post-operative picture of the patient. Can you see any major difference in profile, aesthetic? Absolutely. There's a very minimal morbidity you can see. Mouth opening. As I said, mouth opening, beautiful mouth opening this patient has. And this patient has teeth on the other side, and there's a fibula is placed on this side. So there is always an option in the future that dental implants can be done for this patient. And as a max spec surgeon probably, or as a dental specialist, you people have to take interest in putting implants into this fibula and rehabilitating these patients. Because when you're putting the fibula, still our work is 50% done. When we do the dental implants, I think that is where we can say 100% work has been done. So you people need to take interest, you people need to take further training in putting implants into dental, in the reconstructed bone, be it scapula or be it fibula, and probably you can add on to the patient's quality of life. Now we are going to talk about the scapula free flap, because this is one of the free flap which are being done by our team, and we have done last year we have done highest number of scapula free flap across India, and we are doing regularly for our patients because of its own advantages. So we are not going to get into details of the scapula free flaps. I'll just skip the details. But I just want to show you that scapula, it's a scapula bone. It's present on back side. There are two scapula. It is near to the shoulder joint. So you can see a picture of scapula here. We can take the scapula lateral border, and at times, if it is needed, we can take the tip of scapula. Also can be used for reconstruction, especially for maxillary reconstruction. Scapula is the best solution in today's day. Now we are going to have two cases, important cases. This is the patient who have been operated earlier, and you can see there's a mark, where there's a mark on left side. Nasolabial flap has been done for this patient 1 year back. Now this 4 years back was done, and patient reported to us, when we have seen the patient, there was an ulcerative lesion in lower GBS, or you can say the alveolus where the nasolabial was placed. You can see clearly in this picture. Even though it was a small ulcer, but it was just sitting on the alveolus, and there was bony erosion. So we had planned for segmental mandibulectomy for this patient. Now, for this patient, we have taken only the bone. We have not taken the skin pattern. So, as I said, you can decide it based on your need. You can take only the bone. You can take bone and muscle. You can take bone, muscle, and skin pattern. So it depends on your how much defect, how much tissue is needed for reconstruction. So now you can see we have taken, this is a scapula bone, and this is the vessel. You see a kind of tail thing, this is a vessel there. So these are the harvested pictures. You can see in the third picture that there is a defect. You can see there's a bony defect. You can appreciate. Now we have done the scapula free flap. We have fixed it with the plates and screws and covered it with the muscle. We have taken it, and this is the post-operative result. You can see we have we have put the muscle in the intraoral, which has undergone mucosization, and this is the post-operative donor site healing. Absolutely, patient doesn't have any problem when it comes to scapula harvested. And the important thing is your scarma is totally hidden in your cloths. It is not visible there. So this is how you can appreciate this is a pre-operative, this is the post-operative. Now we have tried to maintain the function, aesthetic of this patient. You can see pre-operative, post-operatively. If you superimpose, you will not find major difference for this patient. So the advantage of scapula, when I was being trained at, I was trained from Germany for the scapula. They used to say the scar hides in the bra line. So whenever we are doing the resection from the leg, many a times the people, they are not the foreigners or, the people in Germany are not very much comfortable with the scar on the leg, because they don't want, they cannot wear the shorts and other things. There were a lot of issues were there. So Europeans and the Britishers are using scapula free flap as the primary flap, giving an edge over the fibula free flap, because of its own disadvantages the scapula carries. And we are also trying to popularize this technique in India with the scapula giving an edge over the fibula. So now this is very important thing which you need to see the X-ray now. See the mandible, how the new mandible have formed. Can you see even a 1% difference in this mandible? Beautifully, the scapula, it unites, because scapula is kind of a cortical and marrow bone is there. Exactly like how the mandible is there. The fibula is a pipe bone. It doesn't have a marrow. It's a cortical bone. But this scapula has got a cortex, it got a medulla, and that is how the post-operative 3-dimensional result. You can see beautiful scapula which is adapted to the mandible. I think that is how we appreciated that scapula gives a beautiful result. So one more last patient we are going to discuss. So this is a case, again it's a locally advanced patient reported to us with a big defect, which is lower alveolus, chin, everything is involved. Now, ideally speaking, if I have to operate on this patient, I need to do 2 free flaps. So because there's a mandible there, there's an intraoral defect, there's an extraoral defect, the whole lip is going to go, chin is going to go. So such a big defect, we have done many double free flaps. Now the scapula, if we use it, for bilobe technique, this this eliminates the need of the double free flap. Now this is the picture of clinical picture. You can see the lower interior is completely eroded. The buccal cortical plate is eroded. This is the three-dimensional picture. I want you to keep this in mind, the three-dimensional picture, because I am going to show you post scapular reconstruction also. So keep in mind, keep looking at this picture, that we have exactly reconstructed this scapula, the resected bone with the scapula. This is a three-dimensional view of view of scapula. Usually we are doing 3D technique, three-dimensional. We are using 3D models for all our reconstruction. We do on table preparation or planning, how much scapula, how we have to do everything. We plan it on table before we enter into our operation or operative theater. So now this is a operative picture. You can see this is our tumor. We have gone 1.5 centimeter beyond the tumor. We have removed complete lower lip, alveolus, chin, everything has been removed. And what we have done here is, we have taken scapula bone along with two paddles. So when I say you can take composite free flap, means we have taken two paddles. Now why we have taken two paddles is, now bone is going to do the reconstruction of mandible. Now there is a defect in buccal mucosa, there is a defect extraoral. So what we have done, we have used this one pedal intraoral and one pedal extraoral for reconstruction. So now there is no need of doing another free flap for this patient. And this is the post-operative result. You can again appreciate that this patient has got a preferably good competence. Now I told you to remember the mandibular anatomy. Now you can appreciate in this picture that how we have put the scapula bone. So you can see exactly, as I said, we do three-dimensional 3D models, we do it, and that's how we have pre-plated. After surgery, we plate on mandible and we fix the fibula like this. So the anatomy of the mandible, we have mimicked it exactly according to how it was earlier. Again, we have presented our this paper of fibula versus scapula at one of the international conferences in Argentina in 2 years back. So now, what is the need of now? So till date, I think being maxillary surgeon into oncology, we are just doing the resections, reconstructions. So now we are looking forward to put dental implants into this into this reconstructed bone. So osteo-integrated implant into this reconstructed bone will definitely, it will add on or enhance the quality of life, and that is where our role. Any of you have any interest in this aspect, this field, you can always contact me, contact Deepak. Get yourself training. Nothing will happen without training. Get yourself trained. If you want to go abroad, if you want to attach with anyone, we have all options. Only your intent should be there to get training into oncology, even for putting implants. So I think it is important for us now that some of you should take up this field where you are doing dental implant restoration for these these reconstructed bone, and then only we are going to give 100%. It is still, I said, we are giving 50%. If you do the dental implant, मैं भी सीना ठोक के कहूँगा कि हमने 100% result दिया. So future directions, probably there are things are going on for tissue engineering. Again, I will not get into these details, but tissue engineering की हम लोग lab के अंदर we try to make the bone and then put that bone. There are various research is going on. I think tissue engineering is one of the things which we are looking forward in the coming time. So before I conclude my talk, I have said 50 times in my presentation, quality of life, quality of life, quality. Earlier, people used to treat just the disease, but now we need to treat the patient. We need to treat the patient emotions. We need to treat the patient adequately so that he maintains a good quality of life. So the quotation goes, a quality of life is more important than life itself.